Hey, I'm Dr. Kat. I'm a licensed U.S. pharmacist. And today we're talking about one of the most important and most misunderstood topics in women's health, and that's hormone replacement therapy, HRT. If you've ever been told HRT is dangerous, that it causes cancer, that you shouldn't take it, I want you to stay with me for the next few minutes because there's a lot more to this story than most women were told. And honestly, women have been left to their own devices for over 2 decades dealing with these symptoms and issues because of how one study was misinterpreted and misreported. I'll break down what HRT is, what medications are used to treat it, what the real side effects are, who can take it, and who probably needs to stay away from it. I'll also walk you through what happened with the Women's Health Initiative study, the WHI study, because you deserve to understand what really happened and not just sound bites. If you're new here, I make videos explaining women's health and chronic illness for all you men out there from a pharmacist perspective and as someone who lives with chronic illness. If you will please hit subscribe so you don't miss next week's video. HRT, also called menopausal hormone therapy or MHT, replaces estrogen and progesterone that has declined because our ovaries produce it, and in around the 4th decade of life in women, we start to lose the supply of estrogen and progesterone. This is the perimenopausal period, menopause. That's it in a nutshell. You're replenishing hormones that your body used to make in abundance. What does it treat? The primary indication is for vasomotor symptoms. That's the technical clinical term. That's hot flashes and night sweats, which roughly affect 40 to 80% of women going through perimenopause and menopause. But HRT doesn't just do that. It deals with vaginal dryness, urinary urgency, so that's genitourinary symptoms, painful intercourse, recurrent urinary tract infections. It also deals with sleep disturbances. These are all driven by hormonal changes. Our mood, right? Our moods change, like depression, anxiety, outbursts that are uncharacteristic to ourselves. They're hormonally driven. And also estrogen and progesterone, they're known to protect your bones against osteoporosis, so broken bones, that sort of thing. This is not a minor medication. It addresses real quality of life issues. Okay, so let's talk about what's actually being prescribed. HRT generally involves one or both of 2 hormones. These are estrogen and progesterone. Estrogen is the workhorse of HRT. It's what relieves most of our vasomotor symptoms. The most commonly prescribed one today is estradiol. There are 3 main types. Estradiol is the one usually replaced. It's bioidentical, meaning it's chemically identical to what our bodies produce, which makes a big difference. There's also conjugated equine estrogen. This comes from horse urine. Yep, horse urine. And it was the one used in the WHI study, and we'll come back to that distinction in just a few minutes. Progesterone is added for women with an intact uterus. So if you still have your uterus, you would take estrogen and then a progesterone. Here's why this matters. Estrogen alone stimulates the lining of our uterus, so it gets thicker and thicker and thicker. This raises the risk of uterine cancers. If you add a progesterone to it, it lowers your risk pretty drastically. Women who have had a hysterectomy, you can go ahead and take an estrogen by itself. Women who have not, you have your uterus still, you need to have the combination of the estrogen and the progesterone. The progesterone options matter as well. Synthetic progestins, it's a difference from progesterone. Synthetic progestins like medroxyprogesterone acetate, which was used in the WHI study, carry different risks than micronized progesterone. Micronized progesterone is bioidentical, so it matches what our body's hormone produces. It's a little tiny round circular pill. I actually take that. The brand name is Prometrium. That's for oral. You take it as a pill. Current evidence suggests that the bioidentical progesterone has a more favorable safety profile, which is why it's prescribed more often. And this is just something to consider compared to the synthetic progestins like medroxyprogesterone acetate. How you take HRT matters enormously, and this is something that gets left out of most conversations. It's not really something we think about. Oral pills go through our liver first. We call this first pass metabolism. And that process affects clotting factors and then can raise our blood clotting issues like potential. Transdermal options, which is through the skin, right? Application on our skin, through the skin. That's patches, gels, creams, sprays. They bypass the liver, so you don't have this massive increase in, I wouldn't say massive, but you wouldn't have the amount of increase of the potential for blood clots as you would with an oral option. They deliver estrogen directly into the bloodstream through the skin. So your skin just absorbs it. And it's the biggest organ, by the way. Skin is an organ. Current evidence consistently show that the transdermal estrogen carries a significantly lower risk of blood clot strokes compared to the oral estrogen that you would take. And of course, this is clinically important. Other delivery forms, we have vaginal rings. You might have heard E-string. You have estrace. They deliver low dose local estrogen for your genitourinary symptoms with minimal systemic absorption, minimal, meaning very little gets into our bloodstream. It just goes to the site. Vaginal creams and inserts work similarly. These are options even for women who cannot take the systemic HRT. So keep that in mind. Let's talk about side effects because they do exist and you should know what you're getting into. Common side effects that often improve with time. Okay, we're talking a couple months. Breast tenderness, bloating, nausea, maybe some swelling. That's with the oral forms. You can get headaches, spotting, irregular spotting, bleeding can happen at least when the first couple months, up to 3 months. Unscheduled bleeding is actually the most common reason women stop early because it's kind of scary when you see that. It's worth knowing that this often resolves, which is why it's very important that you have a follow-up appointment with your physician that's prescribing this at around the 3 to 4 month mark, just to check to see if everything's okay. More significant risks that require a conversation with your doctor. There's a small increased risk of blood clots with oral estrogen, like we just said. Lower with transdermal, okay? A small increased risk of breast cancer with the combined estrogen progestin therapy. The absolute numbers are smaller than most people realize though. We'll cover this more in the WHI section. And for women who start HRT 10 years past menopause, you can have an elevation in cardiovascular risks. So remember that. Now, who genuinely should not take systemic HRT, so oral HRT, these are real contraindications, not just cautions. So we don't want to take it, okay? Absolute contraindications mean do not take it if you have unexplained vaginal bleeding that's not been checked out, personal history of estrogen-dependent cancers, so breast cancer, certain uterine cancers, active or recent blood clot, like deep vein thrombosis, you might have heard of that, DVTs or PEs, pulmonary embolisms, active liver disease because oral estrogen, right, the first pass metabolism, it goes through our liver. So if we have any kind of liver disease, that's a contraindication, and known or suspected pregnancy. Situations requiring careful individual evaluation, meaning it's not completely off the table, but it requires a thorough conversation with your healthcare provider that's knowledgeable in menopause, is if you have a history of heart disease, cardiovascular disease of any kind, like vein disease, that sort of thing. A history of migraine with aura. This is if you have a migraine and before an aura is you see like flashing lights, you see spots, that sort of thing, that's an aura. Again, this is not completely off the table. It's just you need to really have a good in-depth conversation with your medical provider. If you've had gallbladder disease, high blood pressure that's not well controlled. If you have high blood pressure and it's controlled, okay, If you have high blood pressure that's not controlled, you need to have a good conversation and a strong family history of breast cancer. Notice I said careful evaluation. Now, it's not an automatic no. This is where having a menopause specialist provider matters enormously. And here's something important. Local vaginal estrogen, creams, inserts, gels, they have, again, minimal systemic absorption, and it's generally considered safe even for many women who have a contraindication to the oral estrogen, oral systemic HRT. Genitourinary, okay, that's again, their urinary frequency, vaginal dryness, painful sex. They do not have to go untreated, okay? So remember that. The Women's Health Initiative, the WHI, this is that study I was talking about. This changed everything for a lot of women seemingly overnight. The WHI was a massive study that ran from the 1990s through the early 2000s, and the data was published in 2002. It looked at hormone replacement in postmenopausal women, and it found increased risks of breast cancer, heart disease, and stroke in women taking combined estrogen and progestin therapy. The FDA responded with a black box warning in 2003. HRT prescriptions dropped by over 50% that year. Women who were managing their symptoms well and didn't have any problems went off their medications and had to just deal with it. Many never went back on, and I knew a lot of women that did that. It affected a lot of lives in a negative way. And here is what was lost in the translation, though. First, who was in this study? The average age of participants was 63. Most were 10 years or more past menopause, when they started menopause. This is not the population that typically needs to use HRT. Women who start HRT closer to menopause, within 10 years and under the age of 60, have a meaningfully different profile risk. Okay? Meaningful profile risk. This is called like a critical window or a timing hypothesis. The risks identified in older women do not automatically translate to their recently menopausal women. It doesn't. Second, what drugs were used? Okay, the WHI used conjugated equine estrogen and medroxyprogesterone acetate. This is synthetic, it was oral, and it was high dose. Today we use a lot of low dose. We start low, and if we need it, we titrate up. This was not the case. It was synthetic, oral, and it was high dose, not bioidentical. These are not the formulations most used and prescribed today. Current standard of care favors the transdermal, bioidentical estradiol and micronized oral progesterone. Third, how the risks were reported. So the increased breast cancer risk in the WHI was presented as 8 per 10,000 women per year increase in the combination group. That's a very real number, but the way it was communicated to the public as a percentage, not as an absolute number, as a percentage, made it sound far more alarming and critical than the absolute number suggests. It was actually only a 0.08% increase in like breast cancer risk and things like that. So it's much lower, even though it was clinically significant. It's not like the 8% or 26% that was actually reported. And fourth, here is the most current update, and this is big. In July of 2025, the FDA convened an expert panel specifically to reassess HRT guidance and that black box warning that has been in effect since 2003. That warning then became under active review. We have like the Endocrine Society, I think, and then the North American Menopause Society, the International Menopause Society. They have all issued position statements affirming that for recent menopausal women, recently undergoing menopause, under 60, without contraindications, the benefits of HRT outweigh the risks. Big. And I believe in November, they said, hey, we're going to take that black box warning off. So the science has, moved, the goal lines have moved, and the clinical guidelines have changed, and the FDA is catching up. Here's your action plan. Number 1, if you are experiencing significant menopausal symptoms, hot flashes, mood swings, even, all the vasomotor symptoms, genitourinary, and you've been told HRT isn't right for you before all this happens, ask your doctor specifically Am I a candidate for transdermal estradiol, estrogen, and micronized progesterone? Am I a candidate? Has my risk been reassessed with the current guidelines? That's number one. Number two, if your doctor isn't up to date, let's say you go to a general health practitioner, of course, this is in the United States. If your doctor isn't up to date, which they probably are, just in case they're not on the current menopause guidelines, you can ask for a referral to a menopause specialist. The Menopause Society at menopause.org has a certified provider finder on there. It has a link to that. You can put in your state and I think your zip code, and you can find those closest to you. If you can't, ask your pharmacist, ask a nurse friend, something like that to try and, get that answered. And number three, if systemic HRT is genuinely not right for you, consider vaginal estrogen for the genitourinary symptoms, because that's a separate conversation worth having, right? It is not automatically contraindicated in most situations. 2 decades of women having to deal with it, left to their own devices, unnecessarily, might I add, because a study was misinterpreted, misapplied, misreported. That's not a small thing. You deserve accurate information, which is why I'm here. I'll keep giving it to you as long as I'm able. If this helped you, please subscribe and please share it with a woman in your life that you love and who needs to hear it. Drop a comment telling me whether you tried HRT, considered it, or been told you can't have it. I read every single one. I'm Dr. Kat. This is Real Health, and I'll see you next week. Be well.